start off with my topic for today, and I'll be sharing my experience on how we can plan our first Toric lens case. So can I have my slides, please? Right. So planning my first Toric IOL case. Uh, so Toric IOLs basically, if you go to say, are not very difficult to do once you do a good phaco surgery. Or even probably an SICS surgery. It just needs understanding of few things, and that is what I'm going to be discussing here. So there are two sets of things which need to be understood for toric lenses: the theoretical concepts and some practical aspects. So when we talk about what theoretical aspects you need to know, there are few of them, four to be precise. Understanding of PCA, which is posterior corneal astigmatism, that is something that needs to be understood before you venture into toric lenses. The second is SIA, that is surgically induced astigmatism. Again, something which is less understood and needs to be understood better. Then the biometry part of toric lenses and certain nomenclatures with respect to toric lenses. And the practical aspects of toric lens planning are, the pre-operative marking, which is an integral part of the surgery itself, as I'm sure most people would be knowing. And then the intraoperative, guidance, the things that you do differently for a toric lens. So I'll try to cover all these, quickly today. Okay, coming to, according to me, the two most important and misunderstood things when it comes to toric lenses for beginners are posterior corneal astigmatism and surgically induced astigmatism. Now, both of these are things which have been evolving over the last few years. These concepts on these were not understood before, and now they have been understood much better, and as a result, toric lens planning and the results with toric lenses have become much better. So I won't go into detail about posterior corneal astigmatism, but I'll just share an example with you. These are two photographs taken from the Lenstar readings. The one on the left you can see shows the astigmatism of 0.9 at 97, and the one on the right shows again a Lenstar reading showing 0.79 at 24. Now when you say the astigmatism reading, when there's no minus sign, you're talking about the steep meridian. So it's telling you that in the first photo that it's 0.9 at 97, that is the steep meridian. And so this is a with the rule astigmatism because it is steeper vertically, and the second one is 0.79 at 24, which is steep horizontally. So it's a against the rule astigmatism. Now this only is from the anterior cornea, and this is what our traditional keratometers and even the early biometers used to give us. But for toric lenses, considering the posterior cornea also is very important. Now posterior cornea does play an important role, maybe not in all cases, but definitely in few cases. And below, if you see the net astigmatism which has been got by calculating the posterior corneal astigmatism, in the first case 0.9 at 97, the net astigmatism considering both anterior and posterior became 0.44 at 103. So it came down significantly, whereas the net astigmatism for the against the rule case from 0.79 has become 1.07 at 15 degrees. So what has happened is when you consider the posterior cornea, the astigmatism for with the rule has reduced and for against the rule has increased. Now this is what the effect of posterior cornea is. Fortunately for us, most of the modern day calculators, even if you can't measure, have very good nomograms, and this is taken from a nomogram. So nothing much that you have to do yourself. You can easily just feed in that the posterior corneal nomogram and this will be taken care of. But understanding it is important. The second concept is surgically induced astigmatism, or SIA. Again, this is not something that I'll go in detail because recent studies from Warren Hill and all have shown that your SIA has to be closer to 0 than to take it 0.3, 0.5. And I would say only one thing: if you're starting off toric lens practice, for your first few cases, just keep your SIA 0, and that is proven statistically, and literature has shown that keeping it 0 or close to 0 is beneficial. So I would say starting cases, just keep it 0 and you'll be safe. Coming to your other two theoretical parts, that is your biometry and nomenclature. Now, when you say toric IOL biometry, I would say, you have individual IOL company IOL calculators which have their own, but the safest and the best calculator which you can use is the Barrett calculator, which is freely available online. And for the latest version, you should go to apacrs.org and go to the Barrett Toric calculator and just feed in the details there. That will give you the best results. So you feed in all whatever you get from your, keratometry, axial lengths. Ideally, for starting your toric case, again, if you want to be safe, an optical biometer would, according to me, be a better option than going for keratometry from an autoref and ultrasound, because the optical biometer gives you all the parameters that you can feed in. And you feed in all this and you get your toric lens. It will tell you what is the power of the lens, toric lens, the spherical lens, and also what axis you should implant it. So this is with respect to biometry. Now, understanding the nomenclature is important. So most of your toric lenses come in T2, T3, T4, T5, and all these basically are nothing but your cylindrical powers in different at the IOL plane. So these are some of the common companies which have toric lenses and what is their nomenclature. Again, this is a chart which I prepared for myself. So if I have to implant a biotech, I know HFY 40 means 4.5 diopter, or ZCT 225 is 2.25, which is equivalent to T4. So understanding this nomenclature is important, so you know what IOL power you are putting. So that was with respect to the theoretical part. With respect to the surgical part, the pre-op markings and the surgical part itself. Now, pre-op markings, we all know that you have to do the pre-op markings in the sitting position before surgery. And the reason for sitting position is so that there's no cyclotorsion effect. And you have various markers which help you to get 0, 180 degree marks. You have the bubble marker, the gravity pendulum marker. You have, you can do a freehand mark. There are many different methods. I would say for a beginner, you should use a freehand mark, because to start off with, it is best, and then probably if you're not comfortable with that, you can go on to doing the, one of these markers. So I'll just show a small video to conclude. Okay, this is just a video to show you how you should go about doing a marking. You should dry the area well after you've put your paracane eye drops, and putting a speculum, at least in the beginning, is really important. You put the speculum, you make the patient sit on the slit lamp so the chin is stable, and this is just showing you how you can use a simple, one of the gravity markers. And the inks are there. This is for 0, 180 degrees. Ask the patient to look straight. Probably you can put in a torch light and just mark it at 0, 180. The only issue I feel with 0, 180 is that you sometimes end up with parallax errors because of this. Sometimes when the patient is looking up, your marks go slightly lower. So for me, at least for beginners, I would say like this: a freehand mark at 6 o'clock position, which will give you your 90 degrees, is very safe, and you can just do it very easily as well. And it gives you good results if you do it correctly. Now you should try to do it as close to the center as possible, so it will be 90 degrees, but you have smartphone apps which can help you to get better results with accuracy. Okay, coming to surgical part. So after you dry the area well, now I have got a single freehand mark which is at 100 degrees, which I have confirmed with my smartphone. So I'll keep my Mendes ring. So it's important to dry the cornea well before you put the Mendes ring. I keep the Mendes ring at 100 degrees, and now my IOL has to be at 20 degrees. So I don't use the fancy equipment. I just use a Sinsky which has a mark, because I want point marks. I don't want the line marks, because they can also lead to parallax errors. So I mark it at 20 degrees. This is pretty straightforward. Once you do this well, I've got my 20 degree marks, and you can just continue your phaco routinely. Once you've implanted your lens inside, one of the most critical steps is to remove visco very thoroughly from behind the lens, so that you get good rotational stability immediately post-op, and the visco doesn't make the lens rotate. And then you just have to I use a dialer after removing the visco to nudge the lens into position, and my final nudge comes from the irrigation itself, just gently nudging it into position until I feel that they are aligned with the marks. And you can see that how well the lens gets aligned with the marks when you use simple point marks. So these are just some of the tips and tricks which you need to understand while planning toric lenses, and that's about it. So thank you. Uh, yeah, Ronak. Yeah, yeah, yeah. Yeah, because I use an app, but before using the app as well, I used to use freehand mark. I mean, yes, if you are not, yeah, it could shift. It could shift. It could shift, right? It could shift. Yeah, yeah. So, right, right, right. Very true. Uh, True, that is also a good way of doing it so that you hydrate the incisions and do. I mean, there are so many different ways. It's just that, the basic things of doing it remain pretty much the same, the basic principles.